Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric O'Kelly. This week is the Tropical Medicine Update with Jason Jarvis. Jason, welcome back to the program.
Thanks. It's good to be back.
Tell us a bit about yourself, short intro of why you like Trop Med.
Short intro. All right, I'll do my best. So I'm a paramedic. I was a U.S. Army Special Forces medic a long time ago, and I spent a lot of that time and since then working in the tropics and just really developing an interest in trying to help people that live in places where there's a lot of parasites and tropical diseases that just run rampant. And in most cases or all cases, it's largely a function of the kind of economic environment and overall, economic health of the area and the infrastructure and other factors. But yeah, generally people that are living in rural places or slums or places like that in the tropics are they're very susceptible to a lot of these tropical diseases, particularly parasites, which we're going to be talking about a lot today.
And you have got into a PhD program in Trop Med. Tell us about that.
Well, the PhD program is in health professions education, and that's out of Widener University in Pennsylvania here in the U.S. I recently finished my master's in infectious diseases from the London School of Hygiene and Tropical Medicine. So I'm hoping to pair the PhD with tropical medicine in some way and, continue teaching and, gaining more experiences in the world of Trop Med going forward.
Okay, so what's new in Trop Med? What are we going to talk about today?
Well, there's a lot of new things. I was thinking because we're kind of early on into the series here with the Quorum cast. I was thinking we would just do a little bit of a review of the worms that are parasites. So I figured we'd start there.
Sounds good. It's a subject that's near and dear to my heart. I definitely enjoy having a microscope and little friends to look at.
Yes, indeed. Well, I think a good place to start is, we talk about different parasitic worms. And just kind of starting with, how do we classify these? Because we make a lot of references to these worms, and we're using words that were originally Greek or Latin for the most part, and we kind of just throw these words around, when we're talking about these things amongst our peers. But for the people that are just getting into this or wanting to learn more about tropical medicine, I think it's good just to kind of define what these terms are. So when we're talking about, for example, a trematode, it should be known what that term sort of entails. So if we look at the different kingdoms of life, you've got animals, you've got plants, you've got fungi, and you have protists. Within the animal kingdom, you have a total of 9 phyla, or phyla is plural for phylum. So you have 9 phyla of animals, and 3 of those 9 are actually worms. So you've got some phyla, such as the chordata, which are the vertebrates. You've got mollusks, which are things like snails and octopus. But you've got 3 of these 9, like I said, that are just worms, and they are as follows. We've got the Annelida, which are worms that are round and have segments. So those are things like earthworms and leeches. And then you have nematodes, which are roundworms that do not have segments. And then finally you have the Platyhelminths, which are the flatworms. All right, so those are the kind of the big picture terms that we use when we're talking about worms. And then, by the way, the term helminth is Greek for worm. So if you're doing any kind of reading up on parasitic diseases, or you're reading research articles and things like that, you'll see that word used quite a bit in the literature, helminth. Helminth, which again is Greek for worm.
So helminth, as far as remote medic is concerned, it's a topic that's really important for us because there's a lot of pathologies that you're going to see with infestations of different types of worms. And the nice thing is you can find these using either blood smear or in the urine or feces with a microscope. And an austere clinic, you should have the ability with a Newton microscope to be able to diagnose your casualty on a worm infestation.
Yes. Yeah, absolutely. So, if you look at the epidemiological aspect of this, the worm infestations, worm infections, these are pretty rare in the developed countries. So, in places like the Far East, Europe, North America, places like that. These are not very common in our patients that we see, with the exception of the pinworm. Pinworm is a nematode infection that's very universal. So they estimate nearly every human living at some point or another in their life has had a pinworm infestation. And luckily for most of us, this is an infection that's typically asymptomatic, with the exception of perhaps some perianal itching. But the vast majority of patients with pinworm, it's going to be a self-limiting infection because the immune system will eventually kick it out. But otherwise, your parasitic worms are seen very, very predominantly in the developing countries. So again, in the tropics, in developing countries, rural settings, etc. And the epidemiological data says right now, out of I think we're at around 7 or 8 billion people on the planet, that there's approximately 4 billion people in the world who are infected with one type of helminth or another. So this might not be common if you live in Germany or the United States or Norway, but once you get into the tropics, depending on where you are in the tropics, you can expect to see a lot of patients with these infections, many of whom may be asymptomatic. But the ones who are symptomatic, we can look for some telltale symptomology to help us with our diagnosis and ultimate treatment. So going back to our three phyla of helminths, we've got, like I said, the nematodes, the round unsegmented worms. We have the platyhelminths, which are flatworms, and then we have Annelida, which are the round segmented worms. Annelida are not parasitic in the sense that we usually are talking about these parasitic worm infections. Parasitic worm infections, we're talking about a worm that is in the gut tract. It's in one of the body tissues. It's somewhere in the body. Now, Annelida, moving back to that phylum, that does include leeches. So leeches are around and they have segments. And these, obviously, as all of us know, these are parasitic, but they're very transient, parasites. So you go swimming in the lake or the river or whatever, and you come out and you've got a couple leeches on you. Those are, at that point, technically parasites. And, the typical response is to remove them once you see or feel the leech on your body. And even if you were not aware that there was a leech on you, they typically don't hang around for very long. They just want their blood meal, and then they're going to move on. And they're not known to be disease vectors for the most part, unless you get unlucky and there's a secondary bacterial infection after the leech removal. So really, the only two phyla of helminths that we really concern ourselves with in tropical medicine are the nematodes and the platyhelminths. So let's spend a little time on the nematodes, and then we'll shift over to the platyhelminths. So there's some different ways to think about the nematodes. Again, these are the worms that are round without segments. And we can kind of classify them by how we get the infection. And we can also classify them as to where are they in the body. So some of them want to live in the gut. Some of them live in the body tissues, right? So looking at transmission of the nematodes, we can get them from eating food sometimes. We can get them from probably the most common transmission mode is the fecal oral route, which is where you have any kind of stool or feces on your hands that contains eggs or larvae from another person that had this infection, and then you ingest the eggs, and now you have that infection. So fecal oral, and then just orally, as far as like, you eat some food that had helminth larvae in it, and now you are going to enjoy that infection yourself. So that's one way to get, but those are a couple ways to get the helminth infections. Another mode of transition that is perhaps not the most intuitive way that you would think that you would catch a worm infection, but a lot of these are vector-borne. So you're in the tropics sort of minding your own business, and you get a mosquito bite, or you get a deer fly bite, or you get a black fly bite, or you drink out of a river without filtering the water and you ingest a small water flea. So you have one of these arthropod vectors which can bring the infection to you. So that's another way that we can become infected with nematodes. So again, as far as where they are in the body, we have ones that reside in the gut. We can have some that are living in the blood or the lymphatic or the subcutaneous tissues. And you can even have ones that will live, for instance, in muscle tissue. So, for example, Trichinella spiralis, which is the nematode that causes trichinosis, the disease that's commonly obtained from eating undercooked pork. There are nematode infections where there's a visceral larval migrans syndrome. So that's basically you have a larval stage that's crawling through the body tissues, sort of looking for a home. Okay, so that's kind of an overview of the nematodes. If we look at the platyhelminths, the flatworms, the flatworms are divided into two different classes. So we have class trematode, and then we have the cestodes. The trematodes are also known as flukes. So again, if you're reading the literature and you come across the term fluke, what they're talking about there is a flatworm that does not have segments. Okay. The other class of the platyhelminths are the cestodes, and these are flatworms that have segments. So these are tapeworms. So that is those are the two classes of platyhelminths. Okay, and let's talk about the trematodes next. So trematodes are, as far as mode of transmission, they're essentially divided into two different groups, right? So we have trematodes, which are the flukes. These can live in the bloodstream. They can live in places like the gallbladder. They can live in the liver. They live in those sorts of places. And as far as modes of transmission, we have blood flukes, which are also known as the schistosomes, and those are acquired by a larva sort of tunneling through the skin. So these are going to be the blood flukes or the schistosomes. And then the other group of the flukes of trematodes are the ones that are orally ingested. So these are worms flukes that have laid eggs, or the eggs have been shed into the environment, and the eggs are on food that typically grows along the edge of water sources. And then a animal like a cow or a human or whatever eats the plant growing near the water's edge that has the eggs stuck to it, and then that animal or human then becomes infected with the adult stage of the trematode, and those are typically going to be in the intestinal lumen, or they can be in the biliary system or in the hepatic system. But the trematodes that are burrowing through the skin, that are going to be blood flukes, those are, again, the schistosomes, and they like to spend most of their lives in the bloodstream. All right, and then that brings us to the cestodes. So the cestodes are the tapeworms. So we've got many different species of these. The three most common by far that infest humans are the pork tapeworm, the beef tapeworm, and the fish tapeworm. And those are essentially named for the host in which the larva is embedded itself. And because we came along and did not cook the meat sufficiently, then we become infected with that particular cestode with the adult stage, that is. So normally with a cestode or tapeworm infection, the human is carrying the adult stage of the worm inside the intestinal tract. So again, we have the pork tapeworm, which is known as Taenia solium, and then we have Taenia saginata, which is the beef tapeworm from eating undercooked beef, and then we have the fish tapeworm, which is known as Diphyllobothrium latum, and all three of these are living inside the intestinal tract of the humans with the adult stage. These are actually hermaphroditic, so they do not require, so you don't need two worms in your gut to be able to shed eggs. So the adjacent segments of the tapeworm are going to be male, female, male, female. So they sort of mate with each other, and then the female portions of the tapeworm grow eggs. And then those segments are eventually shed with the eggs attached in the stool. And the stool, if it's passed into the environment where we're not using latrines or otherwise filtering that out, then those eggs get out into the environment where they have the chance to infect the next stage in the life cycle, which could be, in the case of Taenia solium, the pig. With Taenia saginata, we've got the cow, and then Diphyllobothrium latum, we've got freshwater fish being the next host in the life cycle. Beyond those three, we've got several other that can affect humans, and all of the rest of these they're infecting humans, and the human is not really the intended host. So in these cases, the human is the accidental host, but we can have development of the organism in the human host with pathology. So the next most common one, beyond the three I mentioned, we have a condition called hydatid disease, and in hydatid disease, the stage of the tapeworm that would normally form in a animal such as a sheep, instead of it forming in the sheep, it forms in the human. So in the human peritoneal cavity, typically in the liver, we have the formation of cysts that are typically, in the case of the dog tapeworm here, the Echinococcus granulosus, we have a hydatid cyst, and it's usually one cyst, and the patient can be asymptomatic with that, and it might not ever be known that there was even a hydatid cyst in the patient unless they take a blow to the abdomen, in which case the cyst ruptures and the patient undergoes a very rapid onset of anaphylaxis as the inside of the cyst ruptures out and stimulates the immune response. So yeah, you've got the dog tapeworm, a couple different species there. and then collectively they're known as the hydatid cyst disease. Excuse me. We've also got sparginosis, which typically affects dogs and cats, and the animals that they eat, such as frogs. We've got Dipylidium caninum, which is also a dog tapeworm, and the mode of transmission there is actually the flea. And then there are two more which are not very common and typically involve rodents in the usual life cycle.
So I find this fascinating that you're mentioning a lot of these infestations that are clinically important for those working in remote and austere environments. And a lot of these roundworms and a lot of the helminths do cause problems that we're going to see as medics. So looking at pinworms is an easy one, but like the filariasis, which you get from the Aedes mosquito, that is a bloodworm. So it's a nematode, non-segmented roundworm, and the filariasis can be seen in blood, and it can cause elephantiasis. And so you mentioned schistosomiasis, which is something that's really important to keep an eye on as well. So when people get out of swimming in an infected lake, they need to have, as I like to call it, a violent toweling off to get rid of all of the wee beasties, so you don't get the schistosomiasis. And we haven't even talked about some of the other roundworms, like ascariasis, that can block up the gut, and to the point where your large intestine is completely blocked, and so they have to come in and surgically remove most of the wee beasties in order for your body to heal from this. So a lot of these are really clinically important.
Absolutely. So yeah, let's we'll shift back over. We'll shift back over to nematodes here in a second. Before we do that, I just want to finish up just a little quick overview of the schistosomes. So as I mentioned earlier, we have phylum Platyhelminth. So it's one of our 9 phyla of animals. Platyhelminths are the flatworms. And within that phylum, we have 2 classes. We have the trematodes and we have the cestodes. Trematodes are flat, non-segmented worms, and the cestodes are flat, segmented worms. The trematodes, which are also called flukes, can be they can be divided into schistosomes, and then there are the foodborne flukes. All of the flukes have the characteristic of they have a 2-animal life cycle. They have a life cycle that goes between vertebrates, in this case humans, and the other type of animal that they pass through are mollusks. So it's very specific intermediate hosts that they go through. They go through mollusks, which are in this case typically snails. So you have snails that are the intermediate host, where there's asexual replication, and then you have the vertebrate, which is where the sexual replication cycle takes place. Okay, so the foodborne trematodes can be prevented largely through not eating plants that have grown up on the side of bodies of water. And if we are going to choose that as a food source, we just need to make sure that we're giving those vegetables or fruits or whatever a good scrubbing before we turn it into a salad or however we're gonna prepare that. Okay. So in the case of the schistosomes, though, the schistosome trematodes, this is not foodborne. This is, as you said, this is something that we can catch just by swimming in a body of water. So yeah, if you're deciding that swimming in Lake Victoria is on your bucket list and you do that, you are going to want to come out of that water and towel yourself off violently, as you said. So as you're drying off, when you come out of that body of water, you may have, if you're in an endemic area, you may have the cercaria stage of the schistosome trying to burrow into you, basically. All right. So we've got 5 different species of trematodes, 5 different species of schistosomes that are clinically important to us in human medicine here. If there's any veterinarians listening, you're probably very well aware of trematodes and how they can get into some of our domesticated farm animals and so forth. So I'll go ahead and go through the life cycle, and then we'll talk a little bit about the different species here. So the schistosome life cycle. We're just going to start with the person coming out of the lake. That's a good place to start, good as place as any. So a person's coming out of Lake Victoria. They decided to swim at the against the advice probably of their medic that was there telling them not to do this. So they're coming out of Lake Victoria. They're coming out of the Nile River. They're coming out of the rice paddy in China or something like that. We're coming out of a body of water that's not moving very quickly. And so it's a body of water where snails are going to be thriving, right? So we come out of this water, and what might happen is the cercarial stage, which is smaller than we can see with our eye. We would need some kind of low power microscopy to see these. So the cercarial stage is on your skin, and as you start drying off, the water beads on your skin tend to get pulled into the hair follicle. That cercaria gets pulled into that, and then they usually use hair follicles to sort of tunnel their way down into the tissues. So the cercaria gets into the bloodstream. While it's out in the environment, as it's going on to you, it has a tail, and once it gets through your skin and now it's in your bloodstream, it loses the tail just so it's a little bit easier to, maneuver itself around. So now it has no tail, and it's essentially waiting to get passed through into the portal circulation into the liver. So once these get into the liver, that's where the schistosomes are going to go ahead. They're going to go ahead and hold up, and they're going to undergo development into the adult stages. Okay, so trematodes, they are sexual organisms. So these aren't like the cestodes, which are hermaphroditic. We've got male and female trematodes. So male and female schistosomes. These are going to mature in the liver. They are going to mature into adults. They're going to pair off, and then they're going to follow the circulation to either the mesenteric circulation around the intestine, or it's going to go to the circulation around the bladder, sort of depending on the species of schistosome that you're dealing with. So the male and female schistosomes, they are mating, and the female they're mating continuously. The female will start shedding eggs, and because the mated pair is in very close proximity to either the intestine or the bladder, as the species dictates, the egg, which has a little tiny spike on it, actually uses the spike to pass through the wall of the blood vessel that it's in, that it's starting off in, tunnels through the outer layers of the organ, the intestine or the bladder, and then once it gets in there, then that egg is just going to sit there and wait to be shed into the environment. Okay, so it's going to be shed in either the feces or the urine. Now, if this patient goes to the latrine in a flush toilet, and it's going to go through the usual filtration and all that kind of stuff, then this is a dead end. But if the patient uses the facilities in the lake or next to the lake or something like that, then the egg has a chance to get back into the water, and at this point the egg hatches, and this cycle, or this stage of the cycle, is called the Mericidia stage. So the Mericidia is now seeking another host, in this case, the mollusk or the snail, in the case of the schistosomes. So the Mericidia is going to tunnel through the outer tissues of the snail. It gets inside of it, and then it's going to start undergoing asexual replication. And the stage we have now inside the snail are the cercaria. So the cercaria are going to come out once they're matured, and then they're going to go off swimming around looking for the next human host. So that's the whole life cycle. We've got 4 species of schistosomes that are going to be setting up residence. The mated pair, they're going to set up residence in the capillary system surrounding the intestinal tract, and this is going to be Schistosoma mansoni, Schistosoma intercalatum, Schistosoma japonicum, and Schistosoma mekongi. All right, so those are the 4 that are going to cause eggs to be shed into the stool. Okay, the 5th species here, Schistosoma hematobium. This is the one that's going to have the male and female pair sitting right just outside the bladder, shedding eggs through the wall of the capillary into the bladder. So that's where that is going to kind of set up residence. From a purely economical standpoint, schistosomiasis, which is the disease when you have a schistosome infection, schistosomiasis is the second most important parasitic disease with respect to economics when we're talking about, people, missing work because they're sick, or children not going to school because they're sick, different manifestations of that. So from an economic standpoint, schistosomiasis is our second most important disease worldwide, and that's only secondary to malaria, which is also technically a parasitic infection.
I find the helminth fascinating, and I've spent time at Liverpool School of Tropical Medicine and London School of Tropical Medicine with their microscopy to look at these helminths. And I think it's an important diagnostic skill for paramedics and remote medics and those working in austere environments, because this is something you can see in fecal smears and blood smears. I did a week in Pavia doing an ultrasound for tropical diseases. It's amazing the things that the ultrasound can see that is a tropical disease. So ascariasis is one of them. And you can look at liver and spleen cysts or the Hayate disease. And these are all things that I think remote medics should be having in their ability, the microscopy and the ultrasound.
Yeah, I totally agree. So I think we'll finish up here in the next few minutes, but one of the key things I wanted to have here as a takeaway point is when we're doing a clinical workup. So we're doing our primary assessment, we're doing our secondary assessment, focus history, and all of our history gathering. It's really, really important that we ask our patients, where have they been? Like where have they been in the last 6 months, 12 months, where they may have picked up one of these parasitic worms, because it might take a while. These are eukaryotic organisms that are not, you're typically not going to be sick the next day or 2 days later like you would with a viral disease. So it typically takes a while for the clinical signs to show up, and the patient at this point might, not even really bother or consider like, oh yeah, I was in this. I had this exposure, 3 months ago or 6 months ago or something like that. So it's very important that we ask where people have been, and not only where they've been, but what kind of risk factors were they exposed to, right? So for example, if I'm in the U.S. and I have a patient come in who's complaining of, they think there's blood in their urine, right? And I start going through my differential diagnosis while I'm getting history and physical exam and working labs and things like that. Okay, so blood in the urine, one of the things on my differential diagnosis would be Schistosoma hematobium, which is your blood fluke that can live just outside the bladder, shedding eggs into that bladder and causing a little bit of bleeding as it does so. So I'd be very interested in, where have you been in the last 6 to 12 months, right? Depending on how long it took these schistosomes to mature and mate and end up in the vasculature around the bladder and so forth. So I want to know if they've been to a place where they could have caught this, and just because you were in Uganda or Tanzania, for example, doesn't mean automatically that you had exposure. So not only do you need to be in that geographic region, you need a specific kind of risk factor. So the way that we catch the schistosomes is, okay, were you swimming in water? Did you go in the lake? Did you swim in the river? Did you have any exposure to fresh water, right? So if we're talking about Tanzania, for example, as the place where our patient traveled, they might say, "No, I wasn't on Lake Victoria. I was on the Indian Ocean side of the country. So I was over in Dar es Salaam, and yeah, I went in the salt water, but I never went in any fresh water." So I would say, okay, saltwater exposure where we don't have schistosome risk, then I'm going to scratch that off the list. But if they say, yes, I was in Tanzania and I was on the west side over on Lake Victoria, and I did go in the water, then the diagnosis of schistosoma hematobium becomes very, very high on my differential diagnosis list.
That's why we have an R in the sampler at the college. The sample is great and it's universal, but that R is vastly important for recent travel.
Absolutely. I'll just give some other examples here. So looking at some of the other nematodes, right? So we've got some of the nematodes that live in the GI tract. We've got some that live in the tissues. We've got, like I said, Trichinella spiralis, which lives in muscle tissue. So we look at, different risk factors for each of those things. So something like Trichinella spiralis is something you could catch in Europe. You don't have to go to Ghana to get trichinosis. You can get that just about anywhere in the world, really, sort of like toxoplasmosis. The risk factor I'm interested in there is there any chance that you ate undercooked pork? Right. So you want to be kind of specific with some of these questions, right? So did you have any undercooked pork when you were on this trip, right? For example, and that's one of the key questions for trichinosis as an example. If we're looking at the soil transmitted helminths, so some of the nematodes that we can catch where the life cycle of the nematode involves exposure to the environment. So the eggs are shed into the environment, the eggs mature, they hatch, they go into their larval stages, or in the case of ascariasis, the eggs are embryonated and they're in the environment and they've been there for a little while to have been embryonated. Hey, when you were, in Angola, did you ever touch the ground and maybe get some dirt on your hands and then you ate without washing your hands sufficiently? So we would look at some of those kind of risk factors for things like ascariasis as an example. So if we're looking at, sorry, I'm drawing a blank right now. But my brain's very tired. Okay. If we're looking at, was there a hookworm exposure? So the classic hookworm exposure isn't something, we're not catching hookworm from touching dirt necessarily or from food ingestion. We're looking at, did you walk through grass where you had skin exposure to grass, which is where the hookworm larvae tend to hang out and almost like ticks, just sort of waiting for someone to walk by. They latch on, they burrow through the skin, and now you have a hookworm infection, right? And then of course some of the symptomologies that goes with that, such as anemia that we might see. You mentioned earlier some of the filarial worms. So the filarial or the thread-like worms are nematodes that are vector-borne. So they come to you courtesy of some kind of arthropod, and the adult stages of these worms are going to reside in tissues, and then and they're young, so the larval stages of most of these, like you mentioned earlier, these are going to be in blood. So we'll see what we call microfilariae in blood. If the adults are at that stage, if they've mated and the females are shedding larvae, and if we check the blood at the right time. So sometimes you have a kind of a periodicity in when the microfilariae are in there, are in the blood. So you might not, for example, you might not see the microfilariae in the blood during the daytime, but you might see them in their a nighttime sort of blood draw. So looking at some of the risk factors there, you mentioned mosquito bites. So yeah, we're looking at mosquito bites for filariasis. So diseases such as Wuchereria bancrofti, Brugia malayi, and Brugia timori. Those are going to be affected by mosquitoes. Onchocercovolvulus, also known as river blindness, that's going to be affected by black flies, and black flies that specifically are near fast-moving water. We've got Loa Loa, which is the African eyeworm, and that's transmitted by the bite of a tabanid fly, which in North America we call them horseflies or sometimes deer flies, depending on the species. So Loa Loa is transmitted via the bite of that kind of fly. And then last but not least, as far as the nematodes whose adults are tissue residents, you have guinea worm disease, also known as dracunculiasis. And this one's kind of unique among the filarial worms. This is not a bite per se of a arthropod. This is an arthropod that lives in the water where the eggs have been shed. These arthropods, which are called cyclops copepods, ingest the eggs. The eggs hatch inside the copepod, and now there's a little larvae in there. And these cyclops copepods, also known as water fleas, are very small. So it would be very easy to go, dip your glass in the river and take a drink in water that looks fairly clear, but there might be water fleas in there, which contain the larval stage of guinea worm disease. Anyway, that goes through the life cycle where you have males and females living in the tissue of the human body. They tend to gravitate towards the legs. The female will create an ulceration on the foot or on the ankle, which burns as far as the sensation that the patient feels. And their response to that burning sensation on their foot or ankle is, let's go stick this in the river and cool it off, at which point the female sheds eggs through the ulceration into the water, and then the eggs hatch and go into the copepods. So you have the completion of the guinea worm life cycle there.
And the guinea worm is where we get Staph of Asclepius. Explain that to the audience.
Yeah, so the rod of Asclepius, this goes a long way back. There's a couple of different theories on the rod of Asclepius. One theory is that it's from a passage in the Bible. I forget the exact passage, but they're talking about, kind of like a serpent wrapped around a staff. And the one I think is more likely is the rod of Asclepius being based on guinea worm disease, in which, you have this adult female guinea worm, dracunculiasis worm, where an ulcer is being created and there's a little bit of the worm hanging out of the ulcer, which is actually the uterus of the female guinea worm. So the treatment for that a long time ago is practically the same as it is today, where we go get a small stick and we're going to start twisting and rotating that worm out of the body, kind of like a rotisserie. And we're doing it very slowly so we don't break the worm off and then have like this massive secondary bacterial infection with a half dead worm stuck inside the body. So that's the that's still the treatment, is just slow extraction, and the rotisserie technique still works pretty well these days.
I know that's very high on your bucket list of getting to South Sudan, and what is it, 2 villages left after Jimmy Carter eradicated it, to be able to do this and connect with 8,000 years of medical history of how to treat this disease.
Yeah, the Jimmy Carter Foundation has done great things as far as guinea worm eradication. They almost had it a while back. Yeah, like you said, they had it down to like 2 villages or something. And this is now mainly in the lower Saharan desert area of Africa, the Sahel, it's sometimes called. And it actually, because of mainly civil unrest and the inability of scientists and clinicians to get in and get rid of this disease once and for all, it is actually back on the rebound, again because of human conflict in the area.
So you may get your wish after all.
Well, I don't wish this infection or anyone on anybody, but I feel like pulling out a guinea worm is going to be, I think it's kind of like the holy grail of tropical medicine clinical endeavors. So,
indeed. And it's so important for us to learn this. I mean, there's 8 million deaths each year from helminths diseases. And we need to focus. I mean, we're all about trauma junkies. I get it. But the DNBI, the disease of non-battle injuries, is something we really need to focus on to make sure that we don't lose somebody on the team for something that's quite fixable, is quite treatable.
Yeah, the fear is we're going to have future speaking of diseases, non-battle injuries. Looking at this from a military perspective, in years past, diseases, non-battle injuries have played a massive role in the outcome of different battles, different wars, etc. I was just listening to a podcast by a historian. He was talking about I think it was Corregidor in the South Pacific in World War II. But he said 75% of the Japanese casualties were from disease and starvation. Without even having the Americans there, they had a 75% casualty rate just from those things.
So we definitely need to focus on this as remote medics and not just the sexy stuff. This is what is more important, I believe, for the operational medic.
Yeah, I think a lot of us that were involved with conflict in Iraq and Afghanistan over the last 20 years or so. I think a lot of people got spoiled with great infrastructure and rapid evacuations and tons of resources on the ground, and it's great when we can do that. But there will be conflicts where that's not the case. And we're going to have a lot of people on the military and the civilian side that are going to be at great risk of a lot of these diseases that people just don't think about very often.
And we haven't even touched on the climate change and the fact that the global warming is causing more and more of these infectious diseases, tropical diseases, to be found in places where it's been eradicated for decades. And each week on PubMed, there's more and more publications coming out on case studies of these tropical diseases found in continental United States, here in Europe as well. So yeah, these are the things that we need to learn as austere medics to learn the tropical diseases and infectious diseases. And I'm grateful, Jason, that you continue to pop in to the podcast and educate us on these emerging or re-emerging problems that we're going to see.
Well, it's my pleasure. This is my favorite aspect of medicine, so I really enjoy getting to talk about it, and I look forward to our next talk, Aebhric.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.